Our next paper is Incident and Risk Factors for Interval Aortic Events during Stage Fenestrated Branch Endovascular Aortic Graft. And our presenter is Dr. Nolan Krila-Penn from Mayo.
Thank you for the opportunity to present our work today on the incidence and risk factors for interval aortic events. We have one author with financial disclosures, although all is paid to the institution rather than personal expense. Staged endovascular repair of complex aortic aneurysms may decrease the risk of spinal cord injury. However, staging predisposes patients to longer times before their final repair and the potential for interval aortic events. The incidence and risk factors for interval aortic events during stage repairs is not well delineated, and previous literature is sparse. Our aim is to identify the incidence and risk factors associated with interval aortic events during our staged endovascular aneurysm repair. This was a retrospective single-center review of all patients undergoing planned fenestrated and branched endovascular repair, as well as thoracic stent grafting from 2013 to 2021, in which we included all thoracoabdominal and complex abdominal aortic aneurysms with a planned stage repair. Demographics, presentation, anatomic characteristics, and outcomes were reviewed. And our primary endpoints were incidence of interval aortic events and risk factors for these. We defined interval aortic events into 4 categories, including confirmed rupture, which were radiologic, operative, or autopsy-confirmed ruptures. Those with likely ruptures who had clinical presentations of either cardiac arrest, hypotension, or other clinical findings, along with suggestive diagnostic testing with immediate drops in either hemoglobin, whiteout on chest x-ray, or other imaging findings without true confirmation. Symptomatic aneurysms and also unexplained interval deaths during our staging period were also included. Our cohort consisted of 591 patients who were fenestrated or branched candidates during the study period. 449 were excluded due to single-stage repairs, leaving 142 patients who underwent a first-stage procedure. 22 were not offered a second-stage operation, either due to frailty, patient preference, or a complication during their first-stage repair, and were excluded, leaving a final cohort of patients who were planned for their second-stage repair with 120 patients. 104 of these underwent an uncomplicated completion fenestrated or branched repair, and 16 patients had an interval aortic event. The demographics are typical of this patient cohort. The mean age was 73 in both groups. There were no differences in their cardiovascular or medical risk factors, although there was a non-statistically significant trend toward a higher percentage of female patients in those with interval aortic events as compared to an uncomplicated repair. There was no difference in their family history of aortic disease or presence of an aortic dissection, both including an acute aortic syndrome or a chronic dissection. There was also no difference statistically in presence of genetically triggered aneurysms or history of a previous open or endovascular repair prior to staging. There was no difference in the aneurysm extent, including extent to thoracoabdominal aneurysms, but there was a statistically significant difference in the max aortic diameter, with patients with an interval aortic event having higher and larger aneurysms at 76 millimeters versus 66 millimeters in uncomplicated repair. There was no difference in the location of the max aortic diameter, which was predominantly in the chest in 60 to 70% of the patients. There was a statistically significant difference in the aortic size when indexed for body surface area and when indexed for the patient's height. Multiple types of staging was included in this, including endovascular, which was the primary form of the first stage operation, which included first stage TEVARs as well as arch branch cases. 3% underwent open repair, primarily of the aortic arch and or proximal descending thoracic aorta for a landing zone. 30% underwent a hybrid operation, predominantly TEVAR and carotid subclavian bypass, and 13% underwent staged procedures, most commonly a total arch repair and then extension TEVAR. There was no difference, as seen in the previous slide, there's no difference in the type of staging the patients received in patients with aortic events versus uncomplicated repair, and there were no differences in the number of stages that these patients underwent. There was a trend, although not statistically significant, for differences in the reasons these patients underwent first stage procedure. While the predominant reason was still primarily aneurysmal disease in both groups, there was a higher percentage of patients undergoing first stage procedures for an acute aortic syndrome, dissection, or intramural hematoma, or bulky atheromatous disease and risk of embolization in the interval aortic group. This is a summary of our interval aortic events. 6 patients, or 5% of our total cohort, had a confirmed rupture, as seen here, although a bit misleading by the anatomy. This is a rupture of the mid-descending thoracic in a patient with a B-EVAR. There were 4 patients who had a likely rupture with, again, non-confirmed diagnosis, 4 patients who presented with a symptomatic aneurysm, and 2 patients who were lost during staging interval to an unexplained interval death. The time to interval aortic event was significantly shorter than time to uncomplicated completion repair at 17 versus 82 days in median time. And the dot plot on the right shows a spread of the timing to interval events. Naturally, there is a difference in mortality, nearing 70% in the interval aortic group versus no deaths in the elective uncomplicated completion repair group. It is worth noting this is a single center study with a very highly selected group of patients and a limited number of events, and that few of our cases that are emergent are performed in multiple stages, and our follow-up, particularly for those who have unexplained deaths, is limited. This may also be a potential overestimation of interval aortic events due to our intentionally liberal inclusion criteria. In summary, the incidence of interval aortic events was 13%, for which the main risk factor was aneurysm diameter, which remained significant when indexed both for height and body surface area. These are naturally associated with high mortality, and interestingly, the time to interval aortic event is significantly shorter than those with uncomplicated repair. So in conclusion, staging provides a crucial benefit for the reducing spinal cord injury. However, in patients with large aneurysms, this risk must be balanced to the risk of an interval aortic event, and future study is needed to determine the key optimal factors of patient selection and timing to maximize both spinal cord benefit as well as reduce the incidence of interval aortic events. Thank you.
Thank you. Really nicely presented and nice body of work. Can you talk a bit, earlier you quickly mentioned the idea of frailty in those patients who don't make it to the second stage. Have you hashed out the predictors of those patients who don't reach the second stage and the impact of that on your patient selection for these stage procedures?
Yes, while not the aim of this is actually the aim of a second ongoing study, because this is a major difference in patients. And I'll contend, anecdotally, having gone through the data, there is a major difference in the implication of a first stage TEVAR for a thoracoabdominal aneurysm or complex aneurysm than that of an isolated thoracic aneurysm. So this is something that we're in the process of working on in a separate project.
Thank you. Dr. Bath?
Yeah, John Bath from Missouri. It's interesting that 17 days was sort of the average to an interval aortic event, and the aneurysm is much larger. So have you sort of changed your algorithm? Is it appropriate, for example, at the 2-week mark to take a patient with a 7.5 centimeter aneurysm? Do you think that's enough time to sort of do this? And do you guys use any adjuncts if you're worried about spinal cord ischemia, NIRS monitoring, or I think we've gone away obviously nowadays from using a lot of spinal drains, but this experience spanned a lot of different years. There's probably different usage of spinal cord adjuncts through that period of time.
Yes, excellent question. This has been an evolving practice over the better part of 2 decades, particularly in terms of staging. Particularly early in the experience, there was a longer wait time, and some of these patients also do undergo an open arch reconstruction, which does portend a little bit longer recovery time. Our practice has significantly changed over the course of the years, and now we are pushing for earlier and earlier completion repairs with often 2 to 4 weeks at the most, but generally 2 weeks for patients who are larger aneurysms or higher risk for interval rupture. And for those patients with either a smaller aneurysm or higher risk, we do push these out even closer to 4 weeks, although the practice is generally pushing toward 2 weeks. As far as the spinal cord injury, that has also changed from our paper in 2019, as well as an upcoming one in the Annals of Surgery. We've gone away from prophylactic spinal cord drainage for the most part during our completion repairs, and reserve it only for high-risk patients, those who have had previous spinal cord injury, et cetera. But it is, will become an important adjunct to reconsider as this, becomes an earlier push for staging.
I just want to make a quick comment. Jill Cold-Glazer, one of the authors on the paper. So Jonathan, to your point, some of these patients are, it's a little bit mixed data, IDE versus non-IDE. So you have that necessary interval 6 to 8 weeks before you can get a graft. And that would be a lot of the patients of this cohort. Versus now we don't have an IDE, so we're doing a lot of these as PMEGs. And so we have almost the liberal use to say, this patient's over 7 centimeters, we gotta get this done. And we've gone towards the interval of 2 weeks, saying perhaps this is enough time to get this in with enough time for revascularization of the spinal cord and not have an event. We still are much more likely to not put in prophylactic spinal drains. As Nolan had mentioned, we did study that, and we've had a lot of more complications with putting in prophylactic drains versus having them emergently done if we needed them in the ICU, and we still have good outcomes with that. So it's a little bit different. And we've even gone across the table and talked about, well, if we have over 7 centimeter aneurysm, do we put in a TEVAR, leave them in the hospital for 1 to 2 weeks, and then plan for their second stage? And we've had them rupture in the hospital, and we can't salvage that. So it kind of leaves in the air, are there some people that you pull the trigger on, put in a drain, and do everything at once? And we still don't know the answer to that.
Thanks for that perspective. You have a quick question?
Yeah,
Okay.
real quick. Great, like obviously goes without saying, great presentation, great amount of data. 7.5 centimeter aneurysm, unruptured versus half ruptured. I mean versus half repaired. Unrepaired versus half repaired. Like, which one's going to go first? It sounds like you're saying a half repaired aneurysm is at higher risk than an unrepaired aneurysm. Why?
Absolutely. That's something that we couldn't fully analyze despite going through every possible variable in retrospect that we can, including reviewing every image, every completion image, etc. My personal feeling, not data-driven, is that because there is such a shorter time interval, this has to do with changes in flow dynamics within the aneurysm sac, although that's, again, another ongoing prospective project that we're trying to work on to try to do, but my suspicion would be flow.
I think it's the stiffness. You're stiffening the aorta by putting a graft in it.
I think so. Yeah.
All right, thank you. Let's move on to the next one.
So